like to make a little grooves so I can start deep in the tissue with the clear corneal incision. Diamond knifes are made by Mastel.
One, that,
You're just starting your cataract surgery.
okay.
Just made the incisions. And see, I just puncture the capsule, then take one of the point of tears. If you can always be pushing away, lifting a little bit, you get a vertical. Hydrodissection, I like to start just under the capsule, so sometimes you can do that easiest by almost staying outside the capsule edge. And just a little nudge down and away from the equator helps to loosen it. I've modified the soft shell technique to put the trovisc in here after the hydrodissection. Rid of some of this cortex epinucleus. Try to keep in mind being in the center of the lens because it fractures better. Now we've turned to the torsional higher vacuum setting. Depending on the density of the lens, I vary the vacuum setting. That quadrant didn't tumble out quite as efficiently because it was a little on the large side. Better if they're smaller like this one. Well, we still have half the nucleus there. We can be much more aggressive. When we get to the last hemisection here, then I'll make sure I have my second instrument under the tip. I'm doing phaco, water in the cornea. See, there's still viscoat in the chambers protecting cornea. Find if I can get that out here now with the phaco tip. It's a lot more efficient than with the IA handpiece at the end. Might sting a little bit here. More lidocaine while she's changing tubing to IA. I have two settings for IA. Lower vacuum, so I can titrate better to get this subincisional cortex, and I always start with it. IA1 now. So this is a higher max. I'm not having to turn the port straight back. With the lower vacuum setting, it'll drag out that subincisional better too. Cortex, please. The max, this is a maximum vacuum of 120. We don't even use all of that to scrub the lens epithelial cells off. These aren't the cells that produce secondary cataract, but they do cause the fibrous metaplasia and phimosis of the anterior capsule. Polish, please. Polish mode is just a couple of millimeters of vacuum, so it's quite safe with this silicone tip. And we have it programmed so that the bottle height goes down as well during that part of the treatment, so it makes the posterior capsule flat. Notice how it went in here tangentially. Just to be sure that the patient moves, we're not poking the posterior capsule. And just turn out this probe to position the lens. And I use the highest vacuum here because the cohesive viscoelastics are the most cohesive under high shear vacuum, so it helps to pull it all out even from under the lens, but I still go under the lens just to be sure. And I moved it around to be perpendicular to the paracentesis. Because I want to get under it with the vancomycin. And I like to make sure that Descemet's membrane is not curled up there.
Confirm CPIOD.
Correct.
Cells are moved.
60.
Thank you. Sleep image.
Yes. Once I'm sure to have a sealed incisions, now I have the vancomycin, but I'll just put it in the chamber, but in the bag. And then just the eye to normal tension again with a little more BSS. So I'm checking the pressure with this end of the Uracell sponge and adjusting the wound, or tapping the wound to let off aqueous till the pressure is right. I like to start with the high, which confirms the wounds are sealed, and then bring it down to normal. We're finished your surgery and all went well.
Wow.